DSM-5 discovered that the central issue that determines the severity is the nature between self and other. I have a narcissistic patient who thinks he's superior. I tell you, you're superior in what?
Yeah.
I don't see anything in which I can see you as superior to anybody else. Can you educate me to tell me what is superior? He gets indignant with me and says it's obvious. I say it's not obvious to me.
So, Otto, over the years, you've shifted in how you conceptualize personality organizations. Originally, you described distinct personality organizations, neurotic, borderline, and psychotic, almost as categorical. Do you now see personality pathology more dimensionally, with patients fluctuating along a continuum based on context or stress level?
Patients are pretty stable within the level at which they're functioning. Of course, if a patient suffers from a major depression, they'll develop a psychotic illness. If they develop a schizophrenia, usually schizophrenia is a more permanent organization than, say, major depression. You have in schizophrenia a more severe disorganization, and we really don't know yet what is it that interferes with clear differentiation between self and other that is such a normal function from day one.
Yeah.
And however, in those patients, there's a great difficulty, and there must be genetic, metabolic, many things that we don't know yet.
And so that's different, the schizophrenic patient. But if you talk about personality pathology, could it be that somebody with a borderline personality structure, that person changes depending on the context, or if there's a lot of stress, he or she exerts primitive defense mechanisms, and if there's not so much stress, somebody functions neurotically?
I think there are cases where psychodynamic features influence the development of psychosis clearly. In other cases in which it looks like very genetically determined. The more we look at all psychic functions, the more we see it's always a combination between genetics and experience. When we look at sexuality, when you look whether you consider yourself a man or a woman, it's genetic and assignation of sex. Whether you look at your behavior, whether it's more identified with female patterns or male patterns of behavior, combination again of genetic and when you look at sexual excitement, it's hormonal determined, but it's also determined by love maps. You can generate erotic excitement psychologically, not only by the level of testosterone. So all functioning, we have to learn that subjectivity is one function of the brain tissue, of the nervous tissue, and that it's a function that operates that organizes itself spontaneously, and so that the organization is not at the level of neurobiology, but it's at the psychic level. So we have to, when we talk about the brain-mind. Mind is a functioning of the brain, yes, but it is a functioning that organizes its structure autonomously. That's the interesting new development. A person who has been influencing me in this regard is really Mark Soames. Right. I think he's a very important theoretician. Very, very important.
I heard your love for Mark Soames. We also adore him. But in some, Otto, you say like as I understand you, the personality structures are pretty much stable unless you do work on it. It's not so that you
usually personalities are very stable. And there are patients who have a disposition to psychosis, who have a psychotic structure that you can discover sometimes in mental status examination, and they lack reality testing in some area, and you are surprised, but that's what's happening. And I've had the experience myself. A patient whom I took in analysis, very religious, and who, after a few weeks, decided that he was Jesus Christ. And I think that there was already a psychotic issue going on for years that was hidden behind surface. So, apropos treatment, the psychoanalytic approach to psychosis has been a disaster. The British tried to do psychoanalysis. They learned a lot about mechanism and dynamics, but not effective treatment. The Chestnut Lodge people they were able to help, but in very lengthy treatments in which very intense personality intervention took place. It's difficult to reproduce that without daily contacts over many years. There is now an effort to treat chronic delusional patients whose personality is pretty much still in place, but they suffer from chronic delusions. There are now methods to treat them. Garrett...
Psychoanalytic methods?
Yeah, the method suggested by Garrett, the husband of Nancy McWilliams, who combines cognitive behavior therapy with a psychodynamic approach. He first...
Sounds like an interesting combination.
Yes, it's he has been treating patients with psychotic thinking that he approaches first with a kind of cognitive method that sounds a little like mentalization therapy. Patient who had the delusion of a cat that was his enemy, and he gradually discussed the irrationality of it to the point where the patient was able to see the situation more realistic, and then he started looking at the dynamic that determined the patient having entered into that approach. State. So it's a very sophisticated combination of cognitive behavioral one and psychodynamic thinking. But he does it on a once-a-week basis. Once-a-week basis with patients who are chronically hospitalized
It sounds interesting. Did he do a randomized controlled trial on it or not yet? Did he do a trial to test whether it was effective or not?
Yes, he has. He has several cases who have been effective, and people who have been working with him have been effective. So I think this is a promising new approach, very different from the traditional approach of Michigan, Chestnut Lodge, London.
Interesting. Sorry to get on to, because we're still talking about diagnostics. What is interesting for us is the newest DSM-5, the alternative model for personality disorders, and also the ICD-11. They've moved away from the traditional categories for personality disorders. Yeah. And they emphasize a global level of personality functioning, severity, and trait domains that, the more than distinct diagnosis, they have trait domains and severity. How do you view these changes? How do you look at that, in your opinion?
For the last 30 years, we have suggested that personality disorders can be classified both by different types and by severity.
Yeah.
And nobody paid attention. And finally, they discovered in DSM-5, in the alternative classification of DSM-5, discovered what we already know for 30 years. That is the nature of bureaucratic organization. For me, the committees that diagnose, how to diagnose, are very problematic. They are very problematic. So it seems to me that DSM-5 discovered that the central issue that determines the severity is the nature between self and other. Great discovery.
It is something you already said.
Object relations theory, and they are right.
So it's along your lines.
Yeah. So that the DSM-5 alternative, the criterion A, is perfectly right. The criterion B is the remnant of the 5-factor analysis, and the 5 factors was based on the statistical analysis of thousands of tests done for big population. It has no basis in a really dynamic understanding. Yeah. So there is nothing essential about the criterion B is like the salute to the flag of the 5-factor theory, but has no major basis. They wanted to eliminate narcissistic personality because it doesn't fit into it. Well, thanks God they became intelligent enough not eliminating a very important personality disorders, but it shows the lack of thinking that is unfortunately going into brainless putting together statistical analysis, taking 20 different types of behaviors, mixing them up with thousands of cases and see what factors come up, and these are supposed to be the factors of the personality. When they are they derive from tests and criteria.
You don't see it as clinically relevant.
I don't see. I think that the DSM-5 alternative has become more relevant clinically because of the factor A.
Factor A, which relates to your structural model.
Okay. And the other criteria antagonistic. Antagonistic is such a broad concept. You can be antagonistic for 20 different reasons.
Also, do you believe that these specific typologies, not your personality structures, but these DSM diagnoses as we had them, as a borderline personality disorder, obsessive compulsive personality disorder, are they useful still, or should we get rid of them?
I think that we have to look at what we see frequently. And there are certain disorders that we see frequently. Obsessive compulsive, yes. And hysterical, yes. The confusion between hysterical and histrionic is just a bias. These are different levels of pathology that are usually ignored, and it's all condensed into histrionic. I think the hysterical personality exists as a specific personality type, and there's a continuum between the hysterical personality at the neurotic level, the infantile or histrionic at the borderline level, and the borderline is the most severe type of that continuum.
Right. Yeah, I read it.
I think that that clearly that continuum exists. The paranoid personality exists. The narcissistic personality, the schizoid personality.
Yeah.
The division between schizoid and schizotypal is problematic. The schizotypal is a more severe form of the schizoid.
Yeah.
And of course, very often schizoid and paranoid features go together. Also paranoid and narcissistic. So there are combinations, but the clinical types are relatively few, and we see them again and again.
Yeah.
So we should go
beyond
with the clinical, and then think in each case, how can we explain the origin of that particular behavior?
Exactly.
In other words, we cannot go about combining traits with statistical analysis, but traits should be looked at as particular ways of mental organization that have their own history and development.
Yeah, like you always said.
The narcissistic personality, now we know a lot about the narcissistic personality. I don't know whether you've seen we have a text on the narcissistic personality. Don't know whether you've seen that.
I don't know if I've seen that, but I read your work on narcissistic personality.
And which I think is pretty good. I just wrote a paper, finished last week, about the typical transference development in narcissistic personalities.
Also, I'm sorry for interrupting, because for lack of time, we want to dive into your treatment. Is that okay for you, or to dive into some treatment questions?
Yeah, sure. Yeah,
I'm sorry for interrupting.
Yeah, stop me if I'm talking about things that...
I don't want to come across as rude at all, but I just want to ask some more questions. Also, you developed TFP, of course. How do you compare TFP to other approaches to treat borderline personality disorder, like DBT, schema therapy, and MBT? How do you compare these treatments?
Well, schema therapy uses certain preset frequent patterns of childhood conflict and applies which of these seems to fit the right case. It is it's an application of object relations theory but in a kind of mechanized way, rather than discovering the specific conflict,
Right.
imposes a certain standard frequent conflict. This is what I am critical about schema therapy. About mentalization, mentalization is helpful to point out to the patient that behaviors that he tends to interpret a certain way can be interpreted differently. And if he gives himself the leisure to try out other ways of interpreting what's going on, his relationships may improve. That's totally true. But that's the first part of transference-focused psychotherapy. It does exactly the same. And mentalization-based therapy doesn't pretend to change the personality. When a patient distorts the transference relationship, the therapist helps the patient to normalize his behavior as a learning experience.
Yeah.
We don't normalize it. We want the patient to stick at the severe level, keep it, and then compare it with the opposite.
Yeah.
See, in the...
So you, Otto, you're much more, in TV, you're much more confronting than MBT. It's a different therapeutic stance, as you could say, right? As I know MBT
well, it is an
more
effort to get into the deepest depth that we can of the pathology without resolving it, letting it be, as long as the patient tolerates to continue with us under such a distorted situation.
Okay, because that may lead to dropout as well, right? That is,
yes, sometimes patients don't tolerate it, but when it is well done, patients are aware that the therapist is still a friend.
Yeah.
Yes.
So, in Fonagy tries to normalize the situation. We don't try to normalize it, but we work on... He is not interested in changing personality structure. We are interested in changing personality structure.
Right, yeah.
Same when it comes to the relationist therapists. The relationists who see the patient identifying with the therapist as a learning model. We don't want the patient to identify with the therapist, but want to analyze the transference in sufficient depth for the patient to resolve it.
So you want the patient to feel the you want the patient to feel the anxiety and the conflict.
And
be
and we try
that's
to.
The difference.
There are theoreticians who believe that all personality disorder is due to traumatization.
Right.
Not instinctual conflict of traumatization, and that the therapist should avoid re-traumatizing the patient. We don't think that the therapist traumatizes the patient. If the patient relives an intense trauma in the protective atmosphere of the therapeutic session, that helps the patient. That's not a re-traumatization. Patients who have been sexually abused, and they don't want to talk about it, it disorganizes them. We want them to talk about it. We don't believe in the frailty of patients.
No.
Whenever somebody's thought, this is a frail person, it's an intense, primitive, defensive operation.
I'm very glad that you say so, Otto, because your theory has been misunderstood in many ways as frail patients you cannot treat. And you say the opposite. You say also with psychotic organizations you can treat them. That's what you see. Yeah.
Yes.
And you should even put them in this conflict and let them be aware of it. Huh?
Yes.
Now,
Yes.
now you were saying...
I think that even people who have had the most terrible traumatizations, they should be able to relive them in the context of a protective environment given by the therapist.
Yeah.
Yeah, because in the Netherlands we've had a movement of people who said when somebody has a psychotic organization, you cannot treat them because they're too frail to be treated. They might turn psychotic because they have that organization. So then if they're psychotic, don't treat them. Don't give them psychotherapy. But that is not what you propose. You actually treat these patients.
Patients develop psychotic reactions in treatment. Borderline patient develop psychotic periods. And I tell the patient, I think what you're saying is crazy. And the patient insists that he's right. I'm saying, okay, so we agree that we have incompatible realities. From your viewpoint, that's the situation as you see it. From my viewpoint, that's the way I see it.
Yeah.
So we have an interesting difference. How can we deal with this?
Yeah.
So
you're confrontational.
I confront patients with when it's at the right moment.
Yeah.
I have a narcissistic patient who thinks he's superior. I tell you, you're superior in what?
Yeah.
I don't see anything in which I can see you as superior to anybody else. Can you educate me to tell me what is superior? He gets indignant with me and says it's obvious. I say it's not obvious to me.
Explain it.
So I would like it to be obvious to me.
I get it.
So and I'm not getting into fights with patients. I'm telling them very calmly, but directly what I think.
No, and we saw that today, and you do that very eloquently and elegantly, I think. Now, Otto, it brings me to another point. You were talking about traumas, and traumas, I guess, in psychodynamic theory is something different than the A criterion trauma of PTSD nowadays, but there is a growing group of people, definitely in the Netherlands, but I guess also worldwide, that say, okay, people with personality problems, they have a lot of traumas. A criteria traumas, like rape, like you mentioned, or more broader traumas, like emotional neglect. And the way to treat these patients, whether it be borderline or another personality problem, is to treat these traumas with imagery, rescripting, schema therapy, or EMDR. What is your take on this?
I think that one has to differentiate PTSD, post-traumatic stress disorder, from its etiological function in determining a personality disorder. When you have a post-traumatic stress disorder, you just have the patient relive it again and again within the therapeutic setting. Express your honest empathy with it. I had a patient who criminals forced their apartment and had him and his wife bound to 2 chairs while they were robbing. They were all the days in the apartment threatening them. and threatening with killing them, and finally leaving. And it left him with a typical post-traumatic stress disorder.
Yeah.
6 months later, he still had the same experience. So we went through this, all the detail, again and again, until he could absorb it as something that was now a matter of the past.
Yeah. Yeah.
That's different when you have a personality disorder that has a traumatic experience. It's etiology, because when you have a personality disorder, you have an unconscious identification with both perpetrator and victim. And you have to help the patient discover himself as perpetrator and victim in that interchange, in the transference. So I would use transference-focused psychotherapy. And if in middle of the transference-focused psychotherapy they develop an intense panic, I would analyze that panic within.
Now, also, so people say in this, so I totally understand it, what you're saying, like the victim and the perpetrator, and they both identified with both sides. So in schema therapy, you would say, oh, this is the angry protector, and that's the perpetrator. And in schema therapy, for example, you would say, you would go to the side of the victim, right? Because that victim side stands for a side that has been emotionally neglected, and therefore we need to help the patient process that by imagery rescripting or EMDR or another technique. And then people, like the patient, needs less of that perpetrator. As long as you cure the victim, so to say, with a trauma technique like imagery rescripting or EMDR, then the patient feels less of a need to be the perpetrator, to be so angry all the time, because it's a matter of protecting that victim.
Eventually the patient should be able also to identify with the perpetrator.
Yeah.
And be aware that he could be a perpetrator.
Yeah.
I think that would be a good development to see the total problem that he is inside of his mind.
Yeah.
That
see both sides.
That he's both victim and perpetrator.
Right. Yeah.
A patient whose parents were murdered in his presence in a Nazi concentration camp, and he couldn't get over it, and so I asked him, what did he think was going on in those Nazis who were murdering his parents? Why were they doing that? He didn't want to think about it. I said, I think you need to think about it. These are part of your memory system.
Yeah.
What motivates the devil?
Yeah.
What's in it for the devil?
Yeah.
Why does the devil have to be a devil?
Yeah. To face that part.
Yeah.
So in that way you are processing certain memories and restructuring the way people perceive them.
You look back and have a broader perspective of the situation. Yes, you help the patient gain a broader perspective over whatever it is, and sometimes they are very superficial issues, social determinants. If you were a child and you had sex with your father, and then 5 years later you thought of it as a terrible thing, now you were traumatized 5 years later. I tell the patient, now, why did it seem so terrible 5 years later? Could it have been enjoyable with all that importance he paid to you? Now that's different, that if a child is attacked sexually by a violent father who is drunk, then one has to think, what happened to your father? What do you think went on there? So there are different situations, but you have to also, particularly with sexual abuse, have to think about the exciting aspects of sex.
You touch on a very controversial point there, I think.
Huh?
I think you touch on a very controversial viewpoint of that, I think. Don't you?
That I have a controversial...
I think so. If you're saying that it is socially tainted whether a child is traumatized or not, instead of it's the actual experience.
Yes, sometimes we impose, you have been traumatized. You have been traumatized, you have been traumatized. Right. Oh, don't forget that you've been traumatized.
Right.
That does happen, yeah.
Yeah.
It would happen.
Yeah.
But
And it seems to me that sexuality is such a complex relationship from the very beginning. It has an aggressive element.
Yeah.
Normal sexuality has an aggressive element to it. Stoller has written very important things about all of that. And so I believe there is a false exaggeration of the pathology, the whole thing. Same when you have political persecution, which is terrible to live in a country where you are politically persecuted during the Nazis or during the Argentinian dictatorship. The therapist very often identifies politically with the patient. And the therapist has to remain not mix the countertransference.
You want them to be more objective.
Yeah, but you have to remain technically neutral.
But what I'd like to move on to is your own personal experience, talking about childhood trauma. I read in the book that is written about your life by Frank Yeomans that you were hospitalized as a 5-year-old.
Yes.
And subsequently put into Adlerian therapy by your mother for 3 years.
Yes, yes.
How do you look back on that? Can you tell us a little bit about it?
It was... I remember... I have a memory when I didn't want to eat and was throwing... the first 2 weeks in that instant, I was throwing food away. I was looking... I saw a dog. It was a metal dog, and I threw my food on the metal dog. It was stupid on my... So it was a few days terrible. And then comes a period of complete amnesia. I've never been able to recover a period of amnesia that I had in that clinic. And then there was a period in which I ate voraciously and enjoyed it and enjoyed being there. And it ended traumatically because I swallowed a metal toy, a little cock that was what's the English? A whistle.
Whistle.
And
Right.
I got frightened, and the nurse didn't believe me, and I called my mother by phone and said, I swallowed that, nobody believes me. And my mother called her cousin, who was a very famous psychiatrist in Vienna, Manfred Sackel, who discovered the insulin coma treatment for schizophrenia. He told her, always believe children. So my mother came, picked me up, and took me to the emergency room where they discovered thing in the stomach. So it ended not being a traumatic experience. Major traumas of my life have not been. I had a very happy childhood, basically. I had a severe eating disorder, but I had a severe eating disorder, but
you had a happy childhood.
Huh?
You had a happy childhood despite your severe eating disorder?
Yes.
But explain to me where the eating disorder came from then.
The eating disorder probably came from some conflict, but that I never discovered in my own analysis.
You never
No,
found
and I never had the feeling that I had that I thought it was an interesting experience. It seemed funny to me that I shouldn't have wanted to eat, when after that I very much enjoy eating. I had a tendency to become obese and had to put myself on a diet. So I've...
And also the conflict didn't get back into your life? The subconscious conflict then?
No, except a tendency to overeat.
Right.
But I was able to correct my tendency to overeat by participating in an eating control program of the Mayo Clinic. A one-day experience in which I learned how to eat that has helped me for the last 40 years in one day.
short therapy.
It was a wonderful experience.
Yeah.
But the major traumas of my life have been much later. The emigration and
You moved
it
to.
took me a long time in my analysis to realize how affected I was by those. That year I lived under the Nazis. I was a child. It affected my self-esteem, my self-regard. I wasn't aware to the extent to which, in my analysis, that became an issue. And
So you lived for 1 year under the Nazis, right?
Hitler came to Vienna in March 1938.
Yeah.
I was 9 years then, and I left in July 1939. I was almost 10 at that point.
Yeah.
That was a very traumatic situation. But concrete traumas, the worst experience was the death of my first wife.
Right.
That was extremely difficult.
Yeah.
And I went into a depression that lasted for a year, and I went into psychotherapy with a colleague who helped me greatly. And then my house burned down, but these are the more normal things that happen. My house burned down completely one Sunday while I was working in the hospital.
Oh my God.
And but the death of my first wife was.
I imagine.
Yeah. There are other experiences which have been much less, have been painful but not traumatic.
Yeah.
But that was difficult.
It must have been.
But the childhood, I know cognitively that I must have had an eating disorder for issues. but I never was able in my analysis to resolve them. I've had 2 analyses, and it seemed more an amusing aspect of the past because
It wasn't traumatizing.
I've become very interested, particularly in Viennese pastry. I'm an expert in Viennese pastry.
They're really good.
And so it seems amusing to me that I should be having had that problem.
Yeah, I get it.
No, I think I had a very happy childhood, basically.
Yeah.
Although my relation with my parents was not as good as it should have been. I had a very obsessive mother, and the relationship with my father was a good one, but it had a quality. We never talked with each other, but he enjoyed taking me to restaurants in Vienna, and I would go on the weekends. I would go to restaurants with my father. It was wonderful. By that time, I was 8, 9 years old, 10 years old.
Yeah.
So anyhow.
Yeah. Thanks for sharing that, Otto. Yeah. Thanks so much.
Yeah.
Now, because of time, I would love to talk much longer with you, honestly. But because of time, I have one final question. Because Otto, you've done so much for psychiatry and mental health. You made a big, footprint on psychiatry, especially on the work on borderline patients, I believe. Now, looking back on your life, you're now 97, which is incredible. There are many young mental health professionals beginning their career. What would you advise them based on your own lessons in life? What can you advise these young mental health professionals?
Well, first of all, let me say that it took me a long time to decide to become a psychiatrist. First, when I started medicine, I wanted to become a gastroenterologist. Then I wanted to become a neurologist. And then in psychiatry, I was fascinated by the personality of Ignacio Mateblanco, who was my professor, a great psychiatrist. And I had been interested in psychoanalysis from adolescence on, and connected with psychoanalysts all through adolescence. Yeah. So that got together with psychiatry, and I felt that I had problems in my behavior that I wanted to change. I went into analysis, and the fact that I was able to change my behavior gave me the feeling that I would like to help other people to change their behavior, but interested in treating behavior. I was not interested in schizophrenia or organic brain damage, but I was interested in personality, and so and I tried to learn as much as I could from whatever sources I could. And I had a combination of good luck in meeting extraordinary psychotherapists and the effort. Okay, so if I'm saying this, if there's a young psychotherapist, does he want to become a psychotherapist? Are you talking about people who want to help other people to become psychotherapists?
Yes.
At this point, I would recommend, if they had the money and the time, to get psychoanalytic training in spite of its limitations, and to training in transference-focused psychotherapy. I think the transference-focused psychotherapy is really an expansion of psychoanalysis. It's not competing with psychoanalysis, it's an expansion. And that my being able to do both gives me a tremendous power of operation. And I would like young psychiatrists to do the same, to get into psychoanalytic training without becoming
without becoming without having a tunnel vision.
Get transference focus psychotherapy, which also is not taught as well as it should. But they come when psychoanalysts ask me what to do, I tell them learn transference focus psychotherapy. When transference focus psychotherapists ask me what to do, I say get analytic training. And of course, once if you are really a top-notch transference focus psychotherapist, then you can get your own psychoanalytic training by taking patients in analysis under good supervision, individual supervision with people whom you trust for 2 or 3 years. I learned enormously from my teachers, Mate Blanco, Whitehorn, who was the chairman at Johns Hopkins, Andre Green, Betty Joseph. So I had Edith Jacobson. I had wonderful personal models.
Yeah. So your advice, Otto, is to get really good tutors and also to get to know yourself in therapy.
You have to, and of course you should have I think it's helpful to have a personal psychoanalytic experience. Either a psychoanalytic psychotherapy with a very good therapist or psychoanalysis. I had 2 psychoanalyses which were very different. But you asked me about other treatments. I think cognitive behavior therapies can be very helpful to many conditions, but not for personality disorders, and particularly not for pathological love relations. The cognitive therapists have nothing to say about love. They don't pretend to either. They know their limits. So cognitive behavior therapy is helpful to many anxiety conditions, eating disorders. I think, and I have great respect for Beck personally as a therapist. I think that personality disorders really need a psychodynamic approach. But I think that mentalization-based treatment improves functioning without changing the personality. And Gunderson's treatment helps patients also. Good psychiatric management. So Marshall Linehan can help patients. Everybody can help patients, but I think that
the actual change,
the change of personality structure requires a psychoanalytic treatment. I believe, yes.
Thank you so much, Otto, for your openness and for the sharing of your wisdom. And,
okay, been a pleasure. I'm sorry that I'm limited by my hearing problem. That has been a real obstacle.
We're absolutely honored that you're here with 97 years old.
Thank you so much. And we have a solution for the hearing problem. It works fine. Thank you so much.
Thank you so much, Otto.
Okay.
Thank you.